This is Rural Health Leadership Radio.
Episode 175, a conversation with Tee Faircloth, founder and CEO of Coordinated Care, Inc., also known as CCI.
Right now, we've got a chance to really make a huge impact.
Yes.
And really start to see this rural renaissance.
Welcome to the Rural Health Leadership Radio with your host, Dr. Bill Oxier. Each week, Dr. Oxier has a conversation with a different rural health leader to discuss what's working and what's not working in rural health, along with other topics of interest to rural health leaders. Rural Health Leadership Radio's goal is to improve health in rural America by providing a simple, no-cost means to share information and connect rural health leaders from around the country. And now, here's Dr. Oxier with today's guest.
Hi, everybody. I am your host, Dr. Bill Oxier, and welcome to Rural Health Leadership Radio. Rural Health Leadership Radio is a 501c3 nonprofit, and like most nonprofits, we're always looking for ways to pay the bills and support our mission. And that's why I'm delighted today to thank Coordinated Care, Inc., otherwise known as CCI, for their generous donation to underwrite the cost of today's episode. And it's no coincidence that our guest today is the founder and CEO of CCI, Tee Faircloth. Tee, welcome to Rural Health Leadership Radio.
Hey, Bill.
And so, as I mentioned, Tee is the founder and CEO of Coordinated Care, Inc., known as CCI. And so, Tee, tell us about yourself. Who is Tee Faircloth? What's your story?
Well, I'm originally from a small town in Georgia, but after college, I started my career in New York working in finance on Wall Street. And in that period, I ended up running the bankruptcy and distress desk at Salomon Brothers. And through that, I developed an expertise in industries that needed change and turnaround. And after 9/11, I left finance and started my first company, which was a safari outfitter. And on my first trip to Africa, I realized that none of the clothing on the market was designed for spending extended amounts of time in the extreme African heat. So seeing that need in that industry, I created a line of clothing utilizing nanotechnology, which allowed the clothing to perform while also being good looking. So between those two experiences, I realized I wanted to spend the rest of my career turning around distressed industries and doing so by figuring out where there was a need in industry and an opportunity that had yet to be realized. And ever since then, I've continued trying to find distressed industries and companies to find smart, effective ways to turn them around.
Well, that's interesting and an interesting journey, both literally and physically on your focus there. So is that how you came about to work in healthcare, to focus on healthcare? Yeah,
so I had no thoughts that I would ever enter into healthcare, but around 4 years ago, a friend of mine from college who was practicing in rural Georgia, he knew my background dealing in distressed industries, and he called me up and he suggested I take a look at what's going on in rural healthcare, because he'd sort of seen the crisis firsthand in rural Georgia, and I was very interested in it. And being from a small town, I took him up on it, and I moved onto his floor, and we began working with the Medical College of Georgia in Augusta, and started working with a number of really smart people, and they helped sort of guide the journey. And over a 1.5-year period, just did a deep dive into the healthcare system as a whole, and specifically into rural healthcare. And so we visited a number of rural hospitals and spoke with professors and some of the leading experts, and tried to really understand the overall healthcare system and where rural can really add value in that.
Well, Tee, that's why caller ID was invented. So when a friend that you haven't talked to in a long time that's from a small town in Georgia calls you, you might, no, I'm kidding. That's awesome. So your friend it was a he, I believe you said?
It was a he, yes.
And so is he a provider in rural health, or what was
he's a doctor. He's a doctor who was actually based in Augusta, but he was working in a rural hospital for a time.
Okay.
And so he just called me up, and he'd seen sort of the tertiary side of healthcare, yes, and then suddenly he was thrust into the rural side of healthcare, and he recognized sort of the disintermediation between the two.
Yes.
And he reached out to me and didn't know he was about to have somebody living on his floor for a while, but yeah.
Okay. All right. Cool. That's another interesting story here that you're sharing with us. So thank you for that. Now, Tee, the name of this program is Rural Health Leadership Radio with an emphasis on leadership. So what's your definition of leadership?
Well, I listen every week, and every time I hear that question, it makes me think of my grandfather, who was a high school coach in South Georgia. And one of his favorite sayings when he was talking about another coach was, he could take his and beat yours, or he could take yours and beat his. And to me, that's sort of the essence of leadership, is really helping others to perform better and helping others to perform, and to succeed, and really building a team and helping that team be better together than they could be individually.
Yeah, if you don't mind, if I make an observation here, Tee, I mean, you use the word helping at least a half a dozen times in your definition. No, that's cool. So your definition is about helping, and so is your life story that you've shared with us here, your journey on how you ended up working on rural health. So it fits. So thanks for sharing that with us. Can you give us an overview of CCI, Coordinated Care Inc., and the community that you serve?
Well, we're really focused on, working with both the rural and tertiary hospitals to identify practical solutions to the rural health crisis. With critical access hospitals and the nature of their reimbursement, we're really focused on building out a swing bed network that better identifies potential swing bed patients at the tertiary level of care. And then we've developed an improved clinical protocol, and we have a technological solution to actually help the patients through the journey and get them back closer to home for their post-acute care utilizing the swing bed program. And for the critical access hospitals, this increases their patient census and their economic viability, while also providing a better level of care for patients closer to home.
Yeah, so is this more informational and training? But you mentioned a technological solution. Can you expand on that a little bit?
It's more logistical than anything. Okay. We're really a logistics company helping patients move along the continuum of care.
Okay.
Because the tertiary hospitals are focused on, if you're a tertiary hospital, you have to get a number of patients out per day. Mm-hmm. And what ends up happening is it's more complex to send a patient to a swing bed and to send a patient to a critical access hospital than it is to just get them out the door into a SNF. So what ends up happening is swing beds become the last choice for patients. It's, if they can go to a SNF, they go to a SNF. What we're trying to do is, since the swing bed provides better outcomes for the patient at a lower overall cost to the healthcare system, we want to make swing beds the first choice if a patient will qualify for that program. Interesting.
That makes sense. Can you talk about the data-driven networks of care?
Yeah. So, here in December, and as we move into the 2020s, probably of all the buzzwords you hear in healthcare, data may be the most overused of the buzzwords.
Yes, definitely.
But it can't just be data for the sake of data. The key is getting the right data to the right person at the right time. And our whole concept at CCI is about using data to improve patient care rather than having mounds and mounds of data. There's a data overload. So it's really effectively collecting and utilizing that data to improve patient care is really where we're focused.
Gotcha. Yeah, because I know I've talked to several people that work in rural hospitals in particular that, okay, we've got all this data. What do we do with it?
Yeah.
And so you've got a system, it sounds like?
We've got a system that's collecting and basically utilizing data that can help as if you're a rural hospital with, 25 beds, you can't get the amount of data you're collecting within your individual hospital isn't large enough. But if you can actually amalgamate the data with other rural hospitals, then you can start having, we call it the law of large numbers, but you can have enough data for there to be useful observations from that data.
Yeah, because that's one of the problems I know that, and also I was just talking to a CEO of a critical access hospital last week, and they had a big swing, and I forget what the number was, but he said, well, it's really not that big of a deal because our census is so low. So that's exactly what you're talking about, right?
Yeah, I mean, one readmission can totally change your, one readmission from a swing bed. When you have two swing beds, you suddenly have a really bad readmission problem.
Right. Okay, cool. Yeah, thanks for clarifying that. So you've been talking about swing beds. What is your swing bed program? Can you talk about that?
Sure. Well, as you know, swing beds, allow for subacute care in rural settings, which allow patients to recover closer to home after acute treatment. And they began in Utah in the 1960s. Then 1980, the program was federalized. And with the emergence of critical access hospitals in 1997, they became more of a key component within the healthcare system. But, with swing beds in the current situation with disposition, swing beds are currently the last choice. And so our whole program is identifying potential swing bed patients at the intake at the tertiary hospital, and then those who are likely going to qualify, moving them through the system. So for the large hospital, we can shorten their length of stay, and once they're medically stable, get them for their subacute care quickly to the critical access hospital, which maximizes the utilization of the assets of the critical access hospital while freeing up beds for the tertiary hospital. So it's really a win-win-win situation for the patient and the tertiary hospital and the critical access hospital. The tertiary hospital gets more turnover in their beds, and because of the DRG system, they're getting a fixed rate. The rural hospital gets better utilization of its assets, and the patient gets better outcomes and a faster time home while recovering closer to home.
Got it. So yeah, it all makes sense. I like the win-win-win aspect of that. So, part of this program is all about best practices. So what about best practices for a swing bed program? Do you have any best practices, 2 or 3, that you could share that rural health leaders could realize when partnering with CCI?
Well, I mean, really best practices sort of go across the entire sort of spectrum. And, one of the things I would say, just looking at the healthcare system, is really being open to change, especially in rural areas, because you really have the chance to have a huge impact by being able to embrace change. And so I would say one key aspect is really being open to the change. And then secondly, I would think that as a leader in a rural hospital or rural health system, you have the ability to affect change in a much greater way than, say, a leader in a tertiary hospital, because of the nimbleness and the ability to move quickly to affect that change. Yes. So really, for opportunity wise, as the CEO of a critical access hospital, you can have a much greater impact than you could as the CEO of a 1,000-bed hospital. It's like, a small powerboat versus a giant ocean liner in terms of changing the direction of your hospital.
Right. Yeah. Good points. Thanks for sharing that with us. Now, I know you've also been doing some work in the rural opioid program. Can you talk about that?
Yes. Well, yeah, and it's well known that rural America has gotten hit hard by the opioid crisis, and the mortality rates in non-metro counties are 45% higher than the mortality rates in metropolitan counties. And one of the things we've worked on is really trying to figure out solutions and figure out something that works for the rural PPS hospitals, because those were sort of left behind in a lot of areas. And the rural hospitals have gone from 1,048 rural PPS hospitals in 2016, and now we're down to just 916 as we're recording. The principal reason for that is lack of low patient census. And one of the things we're focused on is how do we move that excess capacity from the liability side of the balance sheet and move that to the asset side of the balance sheet. And at the same time, we've looked at the rural opioid crisis and how do we get care in rural communities. And one of the things we're working on and really working to structure properly is there a way to utilize this excess capacity within rural PPS hospitals to provide better patient treatment for OUD in rural PPS hospitals? And we've just begun work on that, but we're really excited about the possibility of designing a program specifically to work within sort of the abilities and strictures of of a rural PPS hospital to provide inpatient MAT treatment, within a rural PPS hospital.
Interesting, because I know that there's not a lot of substance abuse treatment facilities in rural hospitals, correct?
Correct.
Okay.
And one of the things we're trying to do is, if we can design it in a standardized way, then you can roll them out to, in any area that has a rural PPS hospital and a need for that treatment facility. Then you have and once again, it comes back to data-driven networks of care. We're able to generate data from that to help improve patient outcomes again. And so what we're really trying to do is develop a standardized program that can be implemented in any rural PPS hospital and really have a chance at success.
Okay, so you keep talking about PPS hospitals or critical access hospitals. This is something that's not necessarily designed for them?
With critical access hospitals, because of the 25-bed limit,
yes,
you sort of need some sort of economies of scale. To put in a 20-bed OUD program there or a 20-bed MAT program there.
Yes,
you're taking up 90% of their capacity there.
Gotcha.
So really, with the rural PPS hospital, like our pilot hospital, they're licensed for 94 beds, but they have an average daily census of 14.6 patients.
Got it.
So there's the excess capacity. So what we're trying to do is figure out how do we take that excess capacity and turn that into revenue generation for the rural hospital.
Thank you. I'm starting to connect the dots now, T. So thank you. That makes more sense to me. Well, it sounds like an interesting program, and we need all the help we can get in that area. That's for sure. You and I met at the Critical Access Hospital meeting in Kansas City back in September, and then we've been talking on and off since then. And you sent me a picture of your office building. Can you talk about that?
Well, I mean, I can talk about that for hours. So what's great about, how we're very fortunate is we began work in Augusta, but Georgia has something called the Advanced Technology Development Center, and it's a state-funded program that's designed to promote innovative technological solutions which we're working on with rural healthcare crisis, but it's cross-industry. And the ATDC, as it's known, is located at Georgia Tech, and it gives you access to the professors and the grad students at Georgia Tech to be driving forward sort of innovations in technology and data analytics and neural networks and other sort of advanced technologies. And we're very fortunate to be here, but we've got about 100 different startups. And about a year and a half ago, they started a healthcare technology startup. And now we have over 50 healthcare technology companies here that are all focused on different areas of the healthcare system, primarily tertiary, but we're working on getting other technology companies focused on rural as well. And through that, and through our work with the governor's office and the Department of Economic Development, we've just launched the Rural Health Innovation Council, which is designed to work with companies who are focused on rural health innovation and really provide some sort of support and teamwork for companies who are trying to focus on, rural health innovation.
Very interesting. It sounds like an interesting place to work.
It definitely is.
Yeah, I bet you meet all kinds of people. Are you the only one in the building that went on safaris and designed safari clothing, though?
Pretty confident on that one, yeah.
Okay.
But there's actually the guy, one of the inventors of the Nerf Super Soaker works here, which is one of the claims to fame.
All right. Okay.
So yes.
Very interesting. So if somebody from our listening audience would like to reach out and talk to you, T, is there a good way for them to get in touch with you?
Certainly. My email is t.faircloth at coordinatedcareinc.com, and our website is coordinatedcareinc.com. And on the Twitter sphere, we're CCI Health, and we're on LinkedIn and all the usual suspects.
All right, cool. Well, I will make sure in the show notes that we also include your website and email address if anybody wants to get in touch with you. So, T, you've done a lot of research about rural healthcare after you got that phone call from your buddy on rural health. What scares you the most about the future of rural health? Really,
there are three things that really scare me right now. sort of joke that rural healthcare is sexy. But right now we have real focus on rural healthcare. It's a hot topic right now. And one thing that scares me is that, it's the inability to react. And so if we don't take advantage as a rural health community on the fact that people are focused on rural healthcare right now, that's going to pass by and will just be another flavor of the week where nothing got done. Mm-hmm. So I think being able to react and being able to take advantage of the fact that there actually is some focus on rural healthcare right now, let's take advantage of it quickly because that could pass. And then one of the other things is that sort of scares me is people talk about sort of different possibilities as if there's a silver bullet to fix rural healthcare, and there is no silver bullet. Right. It's a lot of little things coming together to help improve that. And there is no one magic bullet that's going to save us, be it value-based care, be it telemedicine, be it anything else. Those are all sort of arrows in the quiver, but we've got to put together, there is no comprehensive solution. It's a lot of little things coming together. Yeah. And then, the last thing, is really making sure that the economic value in rural communities from rural healthcare stays in rural communities. And so that it's not the economic value within healthcare does not go to the city, that it actually stays local and helps impact those economies. Because when you look at a complex system like the entire rural economic system, you need everything coming together to actually to start to see a rural renaissance that I think we really can see.
Absolutely. Yeah, that's all important. So I understand why all three of those scare you. So let me flip that question around for you. What excites you the most about the future of rural health?
Well, see the prior three and what our opportunities are. I mean, right now we've got a chance to really make a huge impact. Yes. And really start to see this rural renaissance. And, winning begets winning. And it's it's getting small victories for rural and then multiplying on those. And, like a single swing bed patient is worth somewhere between, it can be between $750,000 to $1 million over the course of a year. But it's what it does for it's what it does for the hospital as a whole. And, you can walk into a rural hospital and without asking anybody, you can pretty much tell how they're doing as a hospital just by the attitude of the employees. And people like to be part of a winning team. So let's, it's how do we take advantage of this and the possibilities if we do take advantage of this where we can really, outperform tertiary healthcare.
Yes, these are the best days of our life, as the song goes. Yes. Well, that's great, Tee. So, we've talked about quite a few things here in the short time we've been talking with each other. If our listeners only take one thing away from our conversation today, what should that be?
It's really find your niche and within the overall healthcare system. Find out where you can add value as a healthcare provider that's not, we all hear every day how many problems there are in healthcare. Well, figure out what one solution is where you can be contributing to the solution. Figure out what is one area where you can be doing it. We have a hospital in South Georgia. They've gone from 2 patients a day to 14 patients a day, but they are focused on respiratory therapy. We've got another hospital in Central Georgia where they're focused on TPN, which is the eating from a bag, the total perinatal nutrition. And, they've been able to increase their revenue by $6 million. That wouldn't work for every rural hospital, but it's figuring out within that healthcare system, where can you add value? And to me, that's the biggest thing that rural hospitals should be focusing on.
Yes. What's the one thing that you should focus on? I love that. Thank you, Tee. Tee Faircloth, founder and CEO of CCI. Thank you again for joining us today.
Thank you, Bill, and thanks for all you do for rural healthcare.
Thanks. I appreciate that. I appreciate you sharing your experience and expertise that you are developing there in the office building by Georgia Tech and your journey that you shared with us. Some great stuff. And thank you again. Thank you to CCI for making a generous donation to underwrite the cost of today's episode. It's very much appreciated. And thank you all for listening out there. If you enjoyed today's episode, please go to iTunes, Stitcher, Google Play, whatever your favorite podcast app might be, and subscribe to Rural Health Leadership Radio. And if you'd like to continue the conversation on leadership in rural health, you can also join our LinkedIn group called Rural Health Leadership Radio. Until next week, let's keep working to improve rural health, one conversation at a time.
If you would like to connect with today's guest, please send an email with your contact information to bill@billoxier.com. If you would like to be a guest or suggest someone else as a guest, have a question you would like to ask, or simply want to contact Rural Health Leadership Radio, please use that same email address, bill@billoxier.com. That's BILL@BILLAUXIER.com. You can also visit our website at www.rhlradio.com.
And we'd ask that you please support our sponsor, the Dynamic Leadership Academy for Rural Health. The Dynamic Leadership Academy for Rural Health's mission is to improve rural health, one leader at a time.